instalment in our wonderful series from the Allied Health Practitioners of Far North Queensland. My name is Dr. Cervical. I'm an orthopaedic surgeon based in Cairns, and tonight it's my I have a great opportunity to share with you Laura Rutherford, who's going to talk about hypermobility, which I'm super interested in, and with particular interest in cervical instability. Take it away.
So, I'm Laura. I'm a physiotherapist. I moved up to Cairns last year for my new grad year, and I'm loving it, and I have absolutely fallen into a hypermobility wormhole. And this is something that I see quite often. I've had 8 new patients this week. 5 of them turns out hypermobility is underlying the musculoskeletal condition. So it's something that I really now look out for, and in looking out for it and doing research, I found out that we're not always great at identifying it.
Yes.
So, a bit about my background. So before I became a physio, I was actually a pole dancer and aerialist. I've competed in a few competitions, got a few ribbons. I also used to teach the sport, so I had a real passion for getting particularly women. I had a lot of women whose kids were now in sport and who wanted to do something for themselves. And when I was coaching these women using our basic coaching principles, I had a few that just didn't respond quite so well. Looking back, I think I have a few suspicions as to why. I graduated physiotherapy in 2023. I spent last year studying migraine management, clinical Pilates, starting to look into pelvic health, and then this year I've had a few health issues of my own. I've had a lot of joint pain, I've had to cut back hours, and underlying all that, I've realised that something I've always known about myself has actually been a main contributor to this joint pain. And now I'm seeing it a lot in other patients, so I've taken a real deep dive. So, just to overview what I'm going to talk about tonight, we're going to go through what hypermobility is, some of the risk factors and common comorbidities, how we can assess it, and then dive a bit into upper cervical instability. I'm going to give you some practical management strategies and a little bit of lifestyle advice and pearls of wisdom that I often give my patients. So, what is hypermobility? Not to cut my talk short, we don't really know. So, as a definition, hypermobility is an excessive range of motion in joints. It occurs naturally in a lot of people, so we think, according to the UK Hypermobility Syndromes Association, about 10% of people are actually problematically hypermobile. There is no definition of hypermobility as a medical condition. There is no real measurement, there is no cut-off point, so it's a bit hard to define, and it can affect multiple body systems. So any musculoskeletal joint, but as I'll talk about later, it also affects us in a lot of different ways, including cardiac, gastrointestinal, a lot of pelvic health, and a few other neurodivergencies and mental conditions as well. So it tends to be changes in the collagen or the fibrillin, in the actual proteins of ligaments, tendons, fascia mostly, but it's not always obvious, it can be really well hidden. So as a definition, hypermobility spectrum disorder is what we generally use now. It used to be benign joint hypermobility, now we've sort of put it on a spectrum, and like all spectrums, it's not a straight line from one end to the other. You can go all over the place with different signs and symptoms. The other thing I always like to tell my patients is this is not a death sentence, it's not a disease that you have. The definition of a disorder is it affects your ability to live your life. So I have ADHD, for example. Not everyone who loses their car keys has ADHD. That is a normal human trait. If you lose them every day and you can't get to work, then it becomes a disorder. Some people are a bit flexible, it doesn't affect them. Some people have hypermobility that is causing other musculoskeletal injuries, and that's the one we need to look out for. So, a couple of different types of hypermobility. HSD, hypermobility spectrum disorder, is the most common. Up to 10% of people, but we really don't know. It's very difficult to get research numbers on this. A lot of people go undiagnosed. There was a statistic from the Australian Physiotherapy Association that from the onset of symptoms, usually pain, can take up to 10 years to identify hypermobility. Then we go into our specific conditions. So Ehlers-Danlos, pretty famous one we all know about. It's defined as a rare disease, although new research is saying it might be a bit more common than we thought, with the advent of hypermobile type Ehlers-Danlos being defined as its own syndrome under the 2017 hypermobility assessment protocols. So it's about 1 in 3,500 people, 13 subtypes. Some of them are a little bit more crucial than others, some are a bit more obvious than others. Marfan's is another one. It's again quite rare. Me and my brother both have that one. We can also have secondary or acquired hypermobility, and I have put a bit of an asterisk on these because they're a bit of a nebulous topic. So, going a bit more specific, hypermobility spectrum disorder is when we have hypermobility, but it's subclinical. So it does not meet the definition for Ehlers-Danlos, which is 5 out of 9 on the Bateman scale, plus you have to have some other system involvement as well. So if you're bendy, if we know you've got joint laxity, but you don't meet that criteria, you fall into this condition. And the image here, there's a couple of different signs and symptoms that can crop up because not everyone is flexible. Ehlers-Danlos, we've got 13 subtypes. We can have vascular, which can be quite serious. Classical, that's that one we all see where they can pull their skin out, and that's one of the assessment criteria is being able to pull your skin from the forearm. We usually get a rheumatologist to do the diagnosis of this one. There is a genetic component. Some of the types we can find on a blood test, some of them we can't. Most of it comes down to a disruption in the collagen matrix. So our protein fibres that make up the connective tissue, they do not have the same structure, they do not have the same tensile strength. So very, very stretchy ligaments, very unstable, whole body wide, so we tend to have mitral valve issues and aortic root issues. We can have problems with vision, dental, any system, you name it, a lot of gastrointestinal issues and such. So, moving on to Marfan's, this is actually a picture of me and my brother. In those shoes, I am 6'3", and he is towering over the top of me. Marfan's is similar in that it affects the connective tissues, but it's actually a change in fibrillin. So these ligaments and tissues will stretch, they do not recoil. So it causes a lot of serious issues with the heart. If you have high blood pressure, your vessels will stretch, they will not contract. So the average lifespan is now 76. It was 32, because if we don't know about it, people would just be walking around, that aortic root would just expand and you would just have a catastrophic spontaneous aortic disruption, dead before you hit the floor. Now that we know about it, if you suspect you have it, if your doctor suspects you have it, first line testing is to do an eye pressure test, because it also affects the fine blood vessels in your eyes, but they'll also do an echocardiogram. We'll take that, I think it's a Z-score is the measurement that they use. If that's looking at all suspicious, we can do preemptive surgery. So this one, you get a lot of musculoskeletal signs. Looking at my brother, very tall, very slim, long fingers, arachnodactyl is a sign of it, long limbs, your arm span to height ratio will be a bit questionable. You get a high arch palate, a lot of dental crowding. You also get a downsloping orbital fissure, which you don't always get all of these. You can have Marfan's without looking like Marfan's, which is where I am, but a lot of times it's quite common. Secondary or acquired. So it's a bit of a chicken and egg situation. We'll go with acquired first. That's hypermobility from dance or gymnastics. I'm flexible because I did dance. A lot of the times they were flexible before they started dance, even as a 4 or 5 year old. That's why they were good at dancing and why they continued it. If you have the right strength and the right control, you can take full advantage of hypermobility. It actually becomes a benefit in these sports, but you don't get the hypermobility from the sport. Other conditions, so Down syndrome, we get a lot of hypermobility there. Anytime we have like a stroke, you can get that really reduced muscle tone. It's not a true hypermobility in that the ligament or the fascia is impacted. It is a lack of muscle control resulting in joints moving where they shouldn't. So, clinical signs, and these are my flags that I start to look for something else happening. There can be quite a lot. So, joint pain is a really common one. If joints are moving too much over time, we're not designed to do that. It can have impacts on the cartilage, it can have impacts on the muscles around it, you can get capsular stretching, all these things. And you can just get pain from a lack of support and stability. So we get tight muscles. A really common side effect of being hypermobile in the joints is you actually become very tight in the muscles, and it's your body's compensation mechanism. We get a lot of headaches, it's related to the upper cervical instability. We get a lot of joint noises, so people who click and crack and pop everything. That's oftentimes, we used to think joint popping was the gas bubble cavitation. In hypermobile people, it can actually be tendons flicking over bone points or joints actually going out of their physiological range. Dislocations are actually quite rare. Back like 50, 60 years ago, it was a criteria for diagnosis of Ehlers-Danlos. Now we know that most people who feel unstable are not pushing themselves into that point where they will get a dislocation. Subluxations can be a lot more common, and there's actually some evidence, it's new, it hasn't gotten too many supporters yet, that if you get people who move their shoulder and get a pretty loud crunch sound, that could actually be a subluxation that's immediately relocating. So keep your eye out for that one. Fatigue. So when your muscles are working overtime to hold your body together, you're going to get tired really quickly. Soft tissue injuries. Again, your joints aren't working the way they should, your muscles are overreacting. You're going to get those injuries, you're going to be put into postures that are not advantageous for your muscles to work. We get a lot of scarring, particularly with Ehlers-Danlos, and it's a lot of stretch marks or that tissue paper type scarring. So it's quite pale, quite fragile skin, and if I see stretch marks on people who haven't had children, who aren't overweight, who haven't lost weight, I tend to look for that as a bit of a sign as well. We get a lot of balance, coordination and proprioceptive issues. So firstly, proprioception comes from a lot of our fascia. If our fascia is implicated, we're not going to be getting that correct input. Also, if your ankles are unstable, your knees are unstable, your hips are unstable, you don't have a good foundation to work from. We can get a lot of scoliosis, we can get the caving in of the chest or the pigeon-chested malformation. We get a lot of poor posture, particularly that head poke, slumping, hanging off your ligaments. So if you don't have the active control, you don't have the ligaments supporting you into that posture, I tell patients it's all like they're going with gravity, and it's not just standing. In sitting, you slump into a chair. If you're on a couch, you sort of flop. If people tend to sit on furniture weirdly, that can often be a sign. So arachnodactyl is that large hand size. Increased arm span to height ratio can be a sign. Long limbs, long fingers, flat feet. If you don't have the ligamentous support in your foot, you don't keep that arch, you can have pronated foot. And then we also get pelvic prolapse or hernia. A lot of fascia, a lot of ligaments holding the pelvic floor together, supporting those pelvic structures. If they don't have the support, we are more likely to have conditions there. So, this is a YouTuber. She has Ehlers-Danlos. She's recently been diagnosed with ADHD, and she does a lot of amazing advocacy work on living with multiple comorbidities. She doesn't look at all hypermobile in that first picture. She's a lovely lady in a cute dress. She actually walks with a walking stick most of the time she does photo shoots. So it's not always obvious, although she does credit her amazing skin to having Ehlers-Danlos. They do not wrinkle. So there's a couple of comorbidities. If you're neurodivergent, you're 2 times more likely to be hypermobile, and there's some studies saying that actual brain scans showing differences between neurotypical people and neurodivergent, that same change is present in some people who are hypermobile without a diagnosis. If they've just not been diagnosed, that could be a point, but it could be similar because it's all to do with the connective tissue. There's a genetic link for a lot of the named conditions. So Ehlers-Danlos and Marfan's well known. If a parent has, and you've got the 1 in 2 chance with Marfan's, or I think it's a 1 in 4 chance off the top of my head for Ehlers-Danlos. Really high rates of comorbidity with POTS, MCAS, autoimmune conditions, a lot of gastrointestinal issues. So, some stats on comorbidities. I found a couple of really terrifying papers. So one of them found that asthma, eating disorders, mitral valve prolapse, in addition to all of the previous slide, was found in interviews with people who have been officially diagnosed with hypermobile EDS, and that the average participant had 5 comorbidities. A more recent study from 2024 did a chart review of over 2,400 patients with hypermobile Ehlers-Danlos in Europe, and found on average they had 11 comorbidities. So additionally, they found tethered cord, cardiac malformation, a lot of Raynaud's. Particular note, they really had a separate paragraph about frequency of upper cervical instability, particularly in women and non-binary patients. So, how common is hypermobility? We don't know for sure. There's a study saying that 64.6 kids between 4 and 7 years are hypermobile. We know that kids are quite bendy. We've seen babies put their feet behind their heads. This is quite normal for children. Drops to 35.6 at 10 years, 11.7 at 13 to 19 years. So all these definitions were based on the Baton scale, which we'll talk about. If you are under 18 and you get a Baton score of 6, you're much more likely to report general musculoskeletal pain, and there's a 300% increased risk of that pain still being present or recurring up to 4 years later. They didn't have data past that because this was a school-based study and the kids graduated. So the average time from the onset of symptoms, 90% of the time that symptom will be pain. To diagnosis is 10 years. That was a statistic from 2022. I did find the study, it divided the 3 life stages of hypermobility. So you've got your hypermobility phase, your pain phase, and then your stiffening phase. We know as we get older we get stiffer, so for hypermobile patients this can actually work in our benefit because you get a bit more stability. But, as I see often in clinic, if you've got those maladaptions to manage the hypermobility, then you stiffen up and you still can get the complications down the road. Also, they were assessing this with the Baton score, which misses a lot of people. So we know that you're not going to, at least one of the criteria, 87.5% of diagnosed hypermobile people cannot do that test. It's actually more indicative if you can't touch your toes that you're hypermobile, because touching your toes is normal range of movement. If you're hypermobile, you're likely to have tight hamstrings. You're less likely to be able to do it. So if you're looking at kids and one of them can't touch their toes, they're probably the more bendy one, which is a little bit back to front. So, no clinical tests for hypermobile patients. If you're in that subclinical level, it's not much at all. There was an article I read after I was writing all of this. I got an ad for a new study and documentary coming out where they may have found a gene marker for the hypermobile type of EDS, but it's going to be quite a while until that makes it to market as a test, if ever. Marfans and EDS, you can do genetic testing for those. They have identified specific, what's the word I'm looking for? Specific, markers. Yeah, gene markers that contribute to you. There's 2 types for Marfans, 3 or 4 for EDS. Some specific testing for Marfan, so that echocardiogram, eye pressure. Hypermobility doesn't show up on imaging. If you've strained a ligament over a lot of time, you might see some thinning or some stretching. It won't show up on an X-ray because it's a movement condition. Imaging doesn't show movement. Clinical tests are the way we usually go. The Baton score is the most commonly taught, it's the most commonly used. It's still recommended by all hypermobility specialists. As of the 2017 commission onto how we're going to assess this. And it still came out number 1, but it is a screening tool. So it has to be done alongside a clinical assessment. It was designed as a screening tool. It was not designed to specifically assess for all hypermobility. You need a good subjective history. A lot of the times I'm already picking up from things they tell me. Recurring injuries is a good one. Never been flexible, tight muscles, I just can't stretch them no matter what I do. I have a few patients who will spend half of their life on a foam roller and they cannot stretch their muscles, and sometimes it's weakness, a lot of times it's underlying hypermobility. You need to do a full joint assessment of the problematic joints. So here's one of the key points with the Bateman score. It doesn't assess all joints. If someone is having trouble with their shoulder, it is not going to pick that up. Also, looking at their range of movement, their passive range will tell you a lot. Muscle length, we get a lot of muscle shortening, posture, and motor patterning. So people who are hypermobile, they tend to breathe a little bit different, they tend to walk a little bit different, they will hang off their hips, they will actually retain oxygen because they're using that air to help splint and provide an artificial stability. So they can breathe in, they can't breathe out fully because they're using that to hold their ribs together. So, the Bateman score, and this is where I'm going to do a little bit of a demonstration. So, the first test, your pinky fingers to 90 degrees. I don't know if you can see it on the computer. I cannot do that. So, I cannot I'll use the black backdrop. I can't get to 90 on either side. The next test is, can your thumb touch your wrist, which close but no cigar. Close, no cigar.
Parallel.
Yeah.
Touch or parallel? It used to be parallel, but now it's
they
touch.
usually add touch, yeah. So, elbow hyperextension. I can get to 10 degrees on one side, I can't on the other, so I've got 1 point so far. With your knees, again, looking for that 10 degrees of hyperextension, I can do that both knees, so I've got another 2 points there. The last test is, can I touch my toes? Which, even with the help of some high heels helping my hamstrings out, I cannot get there. So I'm a 3 out of 9 on the Bateman score. I do not screen positive for hypermobility. However, I can bring my shoulder all the way around there, and you can't see it on the computer. I can stand on the outside of my feet quite comfortably without realising it. So I do have hypermobility. I have migraines from upper cervical instability. I have a hypermobile thoracic spine. None of these are picked up on this score. So if this is our screening tool, you're going to miss me. I asked a couple of patients, I put them through this. So I've got 5 hypermobile patients. Only 2 of them screened positive. So it's a screening tool. As a screening tool, it's really quick, it's effective. That's what we like from screening tools. It's going to miss people who are hypermobile but not flexible. It predominantly assesses the upper limb. We're going to miss a lot of lower limb stuff. It doesn't assess the thoracic, the cervical, the shoulder, hip, ankle, or the TMJ. So when we interview patients with hypermobility, their most problematic joint is the shoulder. And it's the most likely to have a dislocation or subluxation. It's followed by the TMJ and then the ankle. So our 3 most problematic joints not assessed in our main tool. Doesn't mean it's not a useful tool, just means we need to be aware of that and put more thought into our assessment. So, 87.5% of diagnosed EDS patients can't touch their toes. That was in a study for 2 to 7-year-olds. Adjusting for age, 86% of children diagnosed between 6 and 10 years old, so in that most hypermobile phase of life, also couldn't touch their toes. So that's how quickly that muscle action tries to shut down that excess movement. It's actually a lot more indicative. If you can't touch your toes as a kid, that should be a sign to a clinician who's educated that there is something going on in those joints. And I actually had a patient, I think I've put her in as a case study, yes. So she was 32 years old, came in with back spasm, went to pick up a piece of plastic, hasn't been able to move for 3 days. She's been playing professional basketball her whole life. She stopped about 8 months ago. She moved up to Cairns and it's too hot up here to play competitive basketball apparently. 175 centimetres tall, 80 kilograms, so similar to me, moderate musculature, pretty healthy, no underlying health conditions. So sedentary job, walks daily with the dog. When I suggested she might be hypermobile and that might be a cause of her pain, she actually laughed. And she's never been able to touch her toes. She was the least flexible person. This point that she plays in basketball, and I don't know how that sport works, it is a role for unflexible people. because there's less reaching, less everything. She's a bulk sort of get in and elbow them rather than shooting or anything like that, because she can't move. She's tried, she's stretched, she's done yoga, can't move. Baton score of 3 out of 9, so her elbows and one knee were hypermobile. Asked a couple of questions. She had previous knee injuries to the other side, bit of scar tissue there. That's why only one of my elbows is hypermobile. 3 elbow fractures falling off a horse will do that to you. So when I released her hamstrings, she could fold in half and put her palms on the floor and she had no pain at all. So I thought that was an interesting little example of digging a little bit deeper and we find an underlying cause. So to treat these patients appropriately, we need to know if there's hypermobility there. It's a well-known thing in the hypermobile community. Physio doesn't work great, and we tend to find we have pretty poor responses to people with some particular types of injury. Young people with rotator cuff injuries in particular tend to recur, they get a bit better, never feels quite the same, they'll do the other shoulder 12 or 18 months later, and it's always been, you review, what did we miss, what did we do wrong? A lot of the time I'm finding hypermobility. So we get a lot of rates of people who don't improve, same conditions coming back, seemingly unconnected conditions. So first the shoulder will go, then the ankle will go, then the knee, and then the hip, and they just seem to have this grocery list of injuries. They come in, I don't know what's going on, my doctor doesn't know what's going on, we've done blood tests, we've done scans, we've been looking for arthritis and everything like that. Bit too much movement. So, upper cervical instability. So, our neck is very sensitive, it's very important to us. If we get a sore neck, we tend to get very stressed very quickly. It's a very emotional type of injury. It really affects our daily life, our work, everything to do with what we do pretty much. The anatomy of the neck is very specialised. We've got very particular muscles, the way our bones form, the way our ligaments, our discs are shaped. It's a very well-designed machine if it's all working properly. The other issue with the neck, it's a common area for headaches and neck pain. If we get neck dysfunction, that can refer up into the head all the time. It can also cause a lot of TMJ and jaw issues. It's a very sensitive area. Mr. Dean Watson, who does the Watson headache therapy, does a lot of work on C2 in particular and its afferent nervous system. So, the upper cervical spine does a lot about movement of the neck. Most of our neck movement comes from those first couple of vertebrae. So I've got a little table here that I've pulled from a presentation that was at the Ehlers-Danlos World Learning Conference at the start of the year. There's lots of movement for what is only 3 joints. So that atlanto-occipital, not too much. Atlantiolaxial, not a lot. But we've got a lot of rotation, we've got a lot of extension. And those are the directions where those ligaments are providing our stability. We've also got a lot of muscles going on. So it's easiest to think of them in 2 groups. We've got our stabilizers, it's a very long list. They're basically our deep muscles. They are very well placed to keep our head on top of our neck and to keep our neck nice and strong. They are deep, we can't really see them, we can't really feel them. Then we've got our mobilizers. So they're the bigger muscles, got your upper traps coming in, sternocleidomastoids. They're the ones we can see. They're designed for movement. So if you need to quickly duck out of the way, that is what those muscles are for. But if you were just sitting holding your head on, that is what the mobilizers are supposed to do. Now we know that pain has an effect on these. If you have pain, your mobilizers turn off and your stabilizers overact. But we also get this phenomenon where if you're hypermobile and you're not getting the passive support from the ligaments, your stabilizers get very fatigued very quickly. So they will drop out and your mobilizers will come in and take over. So one of the common things we see is coat hanger tightness. If you think about those old wire coat hangers, the top of the shoulders up into the neck, if you are tight through there, if you are tight at the front of the neck, if you are sensitive, if you don't like people touching your neck because it hurts, that's a sign you're using your stabilizers wrong. Your mobilizers are doing everything, your stabilizers are having day off, and that becomes a chronic pattern. So we find that people with the upper cervical instability, some people have no idea they've got it. Some people, especially those with Ehlers-Danlos, the more extreme end of the spectrum, feel like bobblehead dolls, or like they are trying to hold up a bowling ball. Their head is very heavy, they get very tired very quickly. It's a good time to note, hypermobility, laxity and instability are all different. So hypermobility, excessive range of movement in the physiological sphere. So those movements that we are supposed to do, we just have too much of them. Laxity is the accessory movements. It means that there's too much joint play. Instability is actually a patient's subjective experience. They feel unstable. Also, I like to note that flexibility has a lot to do with muscle length. It doesn't really talk much about the ligaments. To be flexible, you need some hypermobility. You also need that muscle extensibility. A lot of times, hypermobile people feel really tight. They cannot stretch. Some people actually don't realise what a normal range is. So they will come in and they can only get their palms on the floor. And they're so stressed because I used to be able to move more, and it's explaining that that is much more than normal. You are now normal. This is what's going on. They also get differences in the stretch receptors and sensation. So that, the proprioception comes into that, the fascia, if you're not getting that right input. They're not really sure what's going on, and they have a lot of difficulty with a lot of exercises because they don't know how they're supposed to move. Cues that work for neurotypical, not hypermobile people don't tend to work so much. So the old pull your belly button to your spine, tense up your stomach, doesn't tend to work. They tend to go way overboard because they are already too tense. When they get told to then tense, they end up sucking everything in, they get into a hunched posture. Same with pulling shoulders back because they don't know where back actually is, where that comfortable position is. Really uncomfortable, really tiring, really stretching their pecs. So they tend to struggle with exercise, they tend to drop out. If you're not active, your hypermobility symptoms often get worse. I didn't have a problem while I was a competitive dancer. I did when I stopped exercising. So the way I usually explain it to patients, I tell them about physiology, I tell them what's going on, and then I explain to them, we all have a Land Rover manual. In our exercise classes, when we're in school learning to do push-ups and HPE, when we go to personal training, when we do any type of sports coaching, we're working with this idea of the body that applies to 90% of people. It does not apply to them. If you're hypermobile, we need to play by different rules. If 90% of the world drives a Land Rover, we all have a Land Rover manual, we all see everyone else driving their Land Rovers, we're having problems and we don't know why. Sometimes it's because we're in a different car. It's still a car, we can still do everything, we're just going to treat it a little bit differently. So, good patient education is key. It can be very stressful to be told that your body is really not holding together properly, so it's important how we explain it, how we reassure, how we provide resources. So referral to a knowledgeable practitioner is a good thing. There are a couple of systems. There's a specialist clinic in Brisbane that only does hypermobility. There's another one in Sydney. There's a couple of really good websites. The Ehlers-Danlos Society actually has some amazing resources. So they have a listing of practitioners who are specialised in this. So they have also multidisciplinary training courses, which are amazing. We can use passive supports for these patients. It goes against the grain as a physio to put someone who's healthy and mobile into a collar or a brace. We've been taught not to do that. But the way I think of it, if you're pregnant and you're having pain, it doesn't hurt you to be wearing a sacroiliac belt for a while. Or if you've done an acute injury and you need to rest that doesn't hurt you. If we use it appropriately, this is a really good tool because these patients don't have the passive support, they're getting fatigued really quickly, they're not using the right muscles anyway. If we can use, say, a collar, it can give you that support that your ligaments are not giving you. It lets you rest your mobilizer muscles, which are overworking. Once they rest, you have a much better chance of being able to deliberately activate the correct exercises. It can make our exercise and physio treatment a lot more effective if you're not trying to fight against your condition. We work with it, we treat it differently, much better results. We can also use different tactics. I tend to use a TheraBand a lot just to provide some compression pressure. Gives you that extra proprioceptive sense, and you can activate muscles a lot easier, or you can build up your joint awareness a lot more. So collars, travel pillows, we tend to wear one if we're on a bus or a train for a long time. We're sitting at work for 9 hours and you're getting tired and falling into a bad posture. Putting yourself in a collar for 40 minutes isn't going to be the end of the world, and it might actually help you get through that day without developing migraine. TheraBand, as I mentioned, really good. That stretch sensation on the skin, if you wrap it around the joint, can help. It can also be really good for a lot of different exercises, even breathing. If I wrap a TheraBand around your chest and you're trying to breathe into the bases, you can feel that stretch from the TheraBand more than you can feel your own body moving. Taping can be really good, proprioceptive K-taping. Again, it's that stretch, it's that sensation. Same with compression. Wearing tight leggings, you can feel where your muscles are, where that movement is a lot easier. We want to go with a few specific exercises. There's a lot to do with breath work and relaxing, just to get all that muscle activation calmed down. So you need to be in a supported, comfortable position. Have a pillow, have your arms propped up, work on relaxing first, then we can work on building up the correct muscles. So Jeannie DeBon is quite famous in Ehlers-Danlos spheres. She does an integrated movement method, which starts with a lot of breath work, goes through specific exercises. It's quite good. There's a few physios who are specialising in it, and they've got their own exercise programs that you can buy if you can't get to see them. There's a couple of books which are really helpful, but we want to do a lot of that stability training, working on getting your arms, your shoulder into your socket before we work on the strength in moving. You want to have that control and awareness of where your body is. I also have a list, so if we take a photo or a screenshot now, these are a lot of resources I provide to a patient. It's a lot of information to be getting in a half-hour session. There's a lot of really good practitioners, especially from the community itself. So a lot of people, if you've fought for 10 years to get a diagnosis, they tend to be quite proactive in putting what they know out into the world, sending out references, things that they know. Hypermobility Without Tears is a really good book. I devoured it in about an hour and a half. Not Just Bendy is that clinic in Brisbane. A couple of websites, so EDS Society, Marfan Foundation, POTS Australia, Arthritis Australia, all have some really good information for patients. There's a couple of Instagram pages that I follow. They give some good little bite-sized exercises. They're all verified professionals, which is good. There's myself, helping here in Cairns. There's a couple of podcasts, so a lot of people find it hard to sit down and read a book, but they can listen to a podcast on their way into work or whatever. We've got Help, I'm a Hypermobile person, Bendy Bodies, Hypermobile Happy Hour, and Inside the Box is actually a pelvic health podcast by a couple of pelvic health physios down in Adelaide. They've got a couple of really good episodes on how to manage prolapse, hernias, being pregnant with bodies that move too much, specifically around pelvic pain and lower back pain. They've got a couple of really good episodes there. Books, so Understanding Hypermobile Ehlers-Danlos Syndrome. It's a bit of a slog, really good information, really good references. Disjointed, there's about 30 doctors and physios who contributed to that one, lots of really good information. Hypermobility handbooks, pretty accessible. And then YouTube, that woman I mentioned before does a lot of videos about how she manages her EDS, which of course not applicable to everyone, but gives you a lot of really good ideas. And here's where these pearls of wisdom come in. When you're sleeping, hug a squishmallow or 2 pillows in one pillowcase. If you're hypermobile, you're sleeping on one side, you're tractioning your shoulder in your sleep. Prop it up on someone. Squishmallows tend to have the perfect size and density. Really helpful. Cheap inner soles, even if you don't think you have feet problems, chuck in a pair of $10 soles from Woolies. It can often help just bring you around. The other thing, the main one, is if you're watching the news, reading someone someone in the streets telling you information about your own condition, you're in the gym, someone's correcting your exercises, just know that 90% of the time, that advice is not for you. It is for bodies that have structured ligament support. If you don't have that, it doesn't matter how well intentioned they are, how well researched they are, if they do not know your condition, it is not for you. Do not beat yourself up about this. It is not made for you. It's a new condition that we don't know much about. It's only just getting realised how common it is. The world is not built for hypermobile people. It is okay. Take a deep breath all the way out. Stop splinting your oxygen. As a takeaway for practitioners, and this is a common saying among EDS practitioners, when you can't connect to the issue, think connective tissue. We know that there's a lot of comorbidities that come with it. Hypermobility can be hard to pick up. You know that saying when you hear hoofbeats, think horses, not zebras? I usually think when there's a lot of hoofbeats, I'm going to check there's not a zebra in the herd. If I've got a patient coming in, they've got a whole list of conditions, usually worth finding if there's something else going on in the background. It won't take it away, it won't fix it, it won't explain it, but it might make things make a little more sense. And I actually had a patient on Tuesday who cried when I told her that I think she's hypermobile. That's why she's 22 with a second rotator cuff injury. You're hypermobile. Your body works a bit differently. Oh, is that why my knee pops and cracks and things? Yep. And she actually broke down and thanked me because it was so validating to be heard and to know that she wasn't going crazy or being a baby because things that don't hurt other people were hurting her. So we can have a huge impact by just looking for this. It's a lot of our understanding that needs to change. What we were taught wasn't always right. We need to move with the research. It's more common than we think. I think that's everything that I wanted to get across. It's just important to me because I've got this condition. I am hypermobile, so is my brother, so is my partner, so is my mum. As it turns out, we tend to move in packs. So it's just a really important thing that we can get right for our patients.
I've got lots of questions, so I'll come up here just because normally I ask from the floor, but I'll ask from up here, and they're not quite in order, so you just have to forgive me. Obviously as a female orthopaedic surgeon, I see a lot of this because I get referred patients who are sort of a bit undifferentiated. We don't really know what's going on. Can you help? They perceive that, got that sort of gentle touch and I'll be able to talk to the patient. And so, yes, I've had a similar journey with my patients across the years. Yeah. I guess I was thinking, my first thought was, why isn't it defined? Why isn't there a measurement? I like to comment that it wasn't a spectrum. I don't really want to call it a disease. Do you see what I mean? But when it's 10%, potentially 10% of the population, I want to call it like, you say with the car, it's part of, the rich tapestry of humanity.
Yeah, we're all different.
Yeah, is that what you use as well? You just sort of say it's part of a spectrum of all of us?
So because I find that a lot of my patients who come in that are hypermobile tend to also already have diagnoses for ADHD or autism or POTS. They've already got this sort of idea that they've got quite a common condition. It's not super rare. It's just different. They just have to do things a bit differently. So when I explain to them about hypermobility, it sort of just adds on to, not only do I have to treat my brain a bit differently, I have to treat my body a bit differently. Okay.
Good. Yeah, that helps me because they do, what I find with the, and this is overgeneralising with the ADHD patient, they've got that pressure of speech. They want to tell you everything, and I think a lot of doctors find that very overwhelming. We're listening for a symptom list. And you get a symptom for lots of and you get lots of symptoms because of course everything hurts. And so we don't really have a really good filter system in the way we're taught to do medicine. I think that's a problem. It
is hard, and something that I've noticed, and I actually found an interesting study on this, I tend to be quite good at picking up these patterns, and in discussions with my colleagues, they're going, where did you pick that up? I found a study saying that people with autism and ADHD actually have improved pattern recognition.
Oh, wow.
So it's a little bit of a
it's part of
hidden
it's a
superpower.
talent. Yeah, I agree.
We can tend to
there's
spot each
something
other.
yeah, I think there's something in it as well. Is it a disease? Just the gastrointestinal stuff. Is it actually a motility problem? Is that what you're talking about?
It is, yeah.
Because it's a collagen motility.
Yeah, because the collagen, you don't have that structure. Everything's
It's
moving
sloppy.
a little bit too much.
Yeah.
And it's even if you're in a weird posture, you fall
Right.
asleep, you sort of twist it all around.
Yeah, maybe.
You can actually be sort of compressing and cutting some things off. A lot of it is though that motility problem.
Okay. What happened? So you had patients up to the age of 33. What happens, like old ladies like me, and I'm even sort of starting to think about, even the 60-year-old with the, distal radius fracture, osteoporosis, all that sort of stuff. Is there any sort of longer term analysis?
Yeah, so usually after that sort of 30s, 40s, we're not on the Bateman score anymore.
Yeah.
So we tend to drop out a lot of the long-term research studies because we're no longer...
Do they pull up with something else? Do they sort of pop up as an osteoporotic? Or?
I see it a lot. So there's some increased risks of arthritis if you're constantly moving joints out where they're not supposed to. Yeah, there's also a lot. So with women, it's fun to be a woman.
Yeah.
So our joint laxity changes with our menstrual cycle.
Yes.
Estrogen heavily linked. Then when we go through perimenopause and menopause, it all sort of falls in a heap again. Yeah, we get a massive spike in 40s and 50-year-old women with tendinopathies, shoulder tendinopathies.
Which might be related to this tight muscle.
A lot to do with collagen. If you've got an underlying tight muscle, then you don't have that tendon strength anymore because it's been protected by estrogen, but now is not. But again, that's another area where we don't have near enough research.
Yep, that's a good one. Okay, now where am I up to? Oh, you said, so the Bateman score looks like it looks at each side, and you said, my elbows are asymmetrical because I've had an injury. Is it always asymmetrical because of injury, or can you actually have asymmetry?
You can.
Naturally?
So your dominant side tends to be less mobile because we've developed more muscle strength.
Really?
Yeah.
Okay.
Especially since 2 of the 5 areas the Bateman score looks at are your hands. Your dominant hand tends to be a bit tighter. So there's people dropping off the score because of that, especially if you work in you're a physio or you're working with tools, things like that. Lots of heavy lifting or even a lot of typing. Yeah. Or you can get stiffness from, associated issues, get carpal tunnel.
So I've got a number of patients that I think might have had Marfans along the years, and I look at the high arch palate and I talk about their height and I talk about compared to not like their siblings generally. I can say have you noticed that you've got a cousin that's really tall like you, but your siblings aren't tall. So I do really push that conversation, and I've got a particular patient who I'm thinking of. And I've sort of said, I think you need to see someone. And he's like, yeah, I've just got back pain. And I'm like, no, I think you need to see someone because you might have a cardiac condition.
Yeah.
And I should have said the one about his eyes as well. But how do you have you got any tips for kind of getting the penny to drop whereby they really need to see someone?
It's a difficult thing. There are 2 clinical tests that we can look at for Marfans. They're not particular to Marfans, they're looking for arachnodactyl. If you can overlap your pinky and your thumb, and if you make a fist and your thumb actually protrudes past the lateral border, sometimes I use that as a bit of chunky. That's not normal.
Yes,
to do that, it gives you a bit of credibility.
Yeah, true.
The other thing is, so when my brother found out he had it, he went in because he was feeling his heart skip, and his GP, her daughter has it, so she was really on the lookout. When I was explaining it to people at work, like, hey, guess what? I've got this fun new condition. One of the patients actually said, I watched that episode of Grey's Anatomy last week.
Okay.
There's an episode, I have no idea what.
Sure.
Man drops in a restaurant.
Great.
Marfans.
Grey's Anatomy. Okay. I might use that.
It can be, it's a bit visceral, it's a bit of a violent scene.
Sure, of course.
But sometimes
I might just get the penny to drop. Yeah, that's what I'm after. So you talked about tight hamstrings, and then you talked about releasing them so that they can touch their toes. What do you do to people to release their hamstrings so that they can touch their toes? That just sounds like you're torturing them.
It surprised the both of us.
Yeah, sure.
So general deep tissue muscle release, Usually you get a couple of degrees difference. Yeah, no pain.
Okay.
That's pretty good. Wasn't particularly sore. Folded in half, she stood up in shock and was like, I'm not going to lie, I didn't expect it to work that well.
Yeah, okay. So it wasn't like you didn't kind of have to get in there and like use your elbows. It was just a normal,
deep tissue muscle.
Normal massage.
And it was just years of that tension, and that's been holding her pelvis back this whole time.
Yeah, that made me think of something else. And then yoga. So people do yoga. Now, I have spent some time doing yoga, and there's two types of people in the world. There's those who just like flop all over the place, wrap themselves up like a pretzel.
Yep.
Generally sort of lower muscle tone, and then there's the stiff as a board, high muscle tone. Sorry, I know I'm generalising. Do you ever see like tight people become more loose, or are you just born that way?
It's a tricky thing. I think a lot of it depends on how hypermobile you are. I've got one patient, he's a child with Ehlers-Danlos, floppy.
Yep.
Just floppy, no idea where his limbs are.
Yes.
He's probably never going to be one of those short people because he just hasn't developed that almost protective reflex to tense up the muscles.
Yeah.
If you do have, and speaking of someone who's quite tight and stretched every day for 5 years while I was a dancer and aerialist, I've never gotten to my splits. So stretching doesn't tend to work. There's a lot of neural tightness often, so neural stretching is important. A lot of strengthening. So a weak muscle becomes a tight muscle. So if you strengthen the hamstrings, that can get you to a normal hamstring length. You generally don't become super floppy.
Yeah, right, okay. Yep, that's what I'm after. When you said the problems with proprioception, does this cohort, are they sort of known as clumsy? Oh goodness, so-and-so sprained their ankle again, or is that the cohort? Is that a clue as well for you?
It can be. Or the other thing, because I often ask if they've sprained their ankle a lot. A lot of times you get people, oh no, I've never sprained, I go over on it all the time, but it's never actually sprained because they've already stretched out that ligament.
But I think that, to me, that's a flag for me, because like you say, sometimes they'll come in and they'll only talk about their shoulder, but with a little bit of questioning you can start to hear that actually it's not just their shoulder, it's a whole lot of joints, and they don't want to talk about it. And I think partly because they're always injured, people have sort of ridiculed them for being clumsy and getting injured all the time, and so-and-so's in a brace again, or so-and-so's on crutches again. And I think, so sometimes I find they're a bit coy to tell me, but also, like you say, sometimes they don't even recognise that they've had multiple injuries.
It tends to go, some people then, now that you mention it,
yeah, right.
I did this and that. But you do get a lot of, internalised shame, anxiety, or, I've injured myself so many times, I need to not do any sport or any movement.
Correct.
Because I just keep injuring
Well, that
myself.
was my next one, was sports dropout. Have you seen any data on the dropout rate? Do they have a higher dropout rate from sport?
I don't have any data on it.
Yeah.
From conversations with patients, they don't tend to drop out because of the hypermobility symptoms. It tends to be more, women drop out of sport when they reach puberty a lot. We know that when we go into the workforce, when we become others, people drop out for various reasons.
Like more social reasons.
But it tends to be about 7 or 8 months after they stop doing sport.
Yes, same. Agreed.
Get worse.
Yeah, I definitely see that, and I do coach them a lot to sort of think about revisiting it. You talked about common sites. So obviously shoulder, patella. I didn't hear you sort of say patella.
You can get a lot of patella. It tends to be in your very athletic populations.
Okay.
They get that kneecap popping out to the side because they're putting that strain and those eccentric lengthening. You've got the strain. If they're doing sport and they're chopping and changing direction, you tend to get all those different forces acting. That's when it goes. If you're not in those sort of intense fast sports, it doesn't happen as much. It can, but not as much.
Yeah, right. Okay. The other ones that I see is base of thumb dislocation in young people.
Yeah.
So they'll come in and they say, I just did something, it went backwards, and now my thumb's sort of can't right.
Yeah, that's sort of skiers.
Yeah, well, no, not metacarpophalangy, actually the CMCJ. So they start coming in with CMCJ pain, which is really unusual in young people, obviously. And they're like, it feels, loose, it feels wrong, and they can sometimes show you some asymmetry. But The other one they get is their metacarpophalangeal joints. I think they can tear the ligaments of their metacarpophalangeal joints, and then they struggle with rip.
Yeah. And the other thing too is because if you're growing up hypermobile, hypermobility tends to be a party trick a lot.
Yes,
especially
agreed.
fingers.
Agreed.
And you're pushing your fingers into
Isn't
the
it funny?
flags.
Yeah.
If you do that too much, too many parties. And
do you think that increases pain later on?
The study's interesting. It's a bit like how, don't click your neck, you'll get yourself. We know that doesn't make arthritis worse.
No.
We do know if you're constantly pushing into those extreme ranges and you don't have the associated specific muscle strength and control, you can stretch the ligaments further.
Okay.
So then you're at more risk of the dislocations.
Interesting. It's a bit like that yoga sort of idea. So what we have in orthopedic surgery, the issue we have is multi-directional instability of shoulders. It's something that we, that kind of everything gets lobbed into that, and that becomes a physio problem. My personal perspective, obviously we do surgery on it, so we do capsular tightenings, but the reporting that I'm hearing, I've done one in 20 years. The reporting I'm hearing is they stretch it back up again. And I think that's a little bit, they kind of get back to what feels normal for them, but they don't sort of have that. They have a period of rehab, they don't have the muscle rehabilitation.
Yeah.
They have a period in a sling, but they don't have the opportunity to build the muscle. So that's what I prefer.
It's that important. So rehab, and when we get taught rehab, when I was doing ortho rehab on my placements, it's a lot about getting the strength and the full range of movement back. There's not as much talk about stability, when often it's important to get the scapula under control, to get your thoracic posture under control, to get your pec muscles stretched so that you're not already in a compromised position when you're starting those exercises. So getting your posture, getting your humeral head seated before we start to introduce range and strength can be really beneficial for these patients, because of course if you don't address what went wrong, but
I think what you've shown me today is that they hear you and they overcorrect, and I think,
and then it's uncomfortable and it's exhausting.
Right.
So then
they start again.
Yeah. So one of the cues I use now, instead of pull your shoulders back, I tell them try and make your shoulders as wide as you can.
Yeah, right.
Because when they're widening, the shoulder blades tend to come back down. They also tend to activate the rotator cuff to really get that humerus sitting nicely. And then if they can keep that in mind as they start moving, they're not already protracted.
I do a lot of labral tightening, so a very gentle, small labral tightening, and the patients will often say that when the day after the operation, they lie back in bed, they're often in those seated beds, and they relax, they can feel that it doesn't fall out of place, which makes me think that that's just the tiny population that I operate on. So compared to the general population, that must be a very small amount. But there must be a lot of people who have that symptomatic instability that can't even describe it.
And it's hard too, because so I use this when I was talking about my ADHD diagnosis, and people went, "How'd you get to 23 without knowing?" You don't know what's going on with other people's heads. You also don't know what's going on in other people's bodies. You were born like this, it's been like this, unless you've had an injury or something's changed. You're not aware that that's not just how a shoulder should feel.
My favourite story for that one was a girl who at the age of 7 worked out that everyone else except her could actually see out of both eyes. And she'd been blind in one eye for her entire life and had no idea that other people had two eyes and they used them. So I just think you're right. Tonight it's been really helpful just getting the conversation really rolling, and I understand there's lots of places and lots of resources, but I think trying to get it out to our community that it's okay that you're a bit supple, yes there's lots we can do to help.
Well, and this is something, because you've been told you're hypermobile and that's what's caused all these injuries in the past.
Yes, true.
It can be pretty stressful.
Yes.
A hypermobile person can do anything that a normal mobile person can do.
Yes.
We just need to have that stability first. We're just at that little level. We can get you to here, and then you're on the same level footing as everyone else.
Yeah, right.
We just need to get you there first. It's just that first little step.
Yeah.
Because if we skip that, that's where the injuries come in.
Yes. And
get
then
it right from the start.
Yeah.
Not better off.
And is there any questions from online? You're welcome to unmute yourself if you want to ask a question. I'll take that as a no. Okay, very good. Well, thank you very much, and thanks for coming in tonight. And I really appreciate your talk, and I hope this allows you to sort of interact with the cancer community on this topic a bit further.
Yeah, well, thanks for having me. It's
Very welcome.
Great opportunity.
Yeah, excellent.